Welcome everyone. Today I would like to present to you my progress on my PhD thesis, which is using personalized treatment to improve early resuscitation in septic patients. Sepsis is a life-threatening condition responsible for nearly 11 million deaths worldwide. Fluid resuscitation is a cornerstone of adequate treatment. Current guidelines recommend a fixed volume of fluid resuscitation. However, personalized therapy may lead to better outcomes. A systematic review and meta-analysis showed that personalized fluid resuscitation reduces the 30-day mortality by nearly 40% without increasing the odds of any adverse events. Clinicians should apply personalized treatment during daily practice in patients with sepsis. Therefore, further trials are needed to investigate the optimal personalization strategy. Based on our findings, guidelines on fluid resuscitation should be revised. My name is Gábor Nagy. I work at the Department of Emergency Medicine and I'm a first-year PhD student as well. I envision a healthcare system where each patient receives the care that is best for them, and my mission is eliminating non-evidence-based data to improve survival in sepsis and septic shock. In order to fulfill them, I have two projects. Both of them started last fall. Let me introduce my first one, which is comparing the safety and effectiveness of personalized versus fixed volume resuscitation in septic patients. Sepsis, as I told you, responsible for nearly 11 million deaths worldwide, and fluid therapy plays an immediate priority and plays a pivotal role in the early treatment. Current guidelines recommend a fixed volume of fluid resuscitation, which is a glaring example for non-personalized approach, but in medicine we know that one size doesn't fit all. Fluid resuscitation is a double-edged sword. It can save lives by restoring hypoperfusion, increasing cardiac output. However, numerous studies have reported the harmful effect of inappropriate fluid administration, such as fluid accumulation syndrome, which seriously deteriorates the function of vital organs, especially the heart and the kidneys. Resuscitating based on personal physiological needs are widely accepted. However, the evidence of its safety and its efficacy is still limited. In this context, our aim is to investigate the effectiveness and safety of personalized resuscitation compared to fixed volume or other non-personalized approaches. Our clinical question is personalized fluid resuscitation safer and more effective compared to fixed volume fluid strategy? We are investigating septic patients. In the intervention arm, we administer fluid based on the patient's own fluid responsiveness in a personalized way, and in the control arm, patients receive fluid resuscitation by fixed volume strategy as the guideline recommends. Our main outcome is 30-day mortality, and the secondary ones are organ support-free days, ICU length of stay, and SOFA score changes. We hypothesize that personalized therapy is associated with better outcomes compared to guideline-recommended fixed-volume strategy in sepsis. We conducted a systematic search in 3 databases last October with a 2-domain search key, when domain 1 refers to the population and domain 2 covers the intervention. At the very beginning, we had more than 9,000 articles, and after the selection procedure, we ended up with 10 eligible articles. Let me talk about my main outcome, which is 30-day mortality. It is the most important and hard outcome in critical care because we want our patient to survive. This outcome was reported in 8 studies with nearly 1,000 patients' data. All studies were randomized controlled trials with a moderate heterogeneity. And if you see the pooled estimated effect, the odds ratio is 0.62, which means that personalized fluid therapy as itself can reduce 30-day mortality by 38%. And it is clinically highly relevant and statistically significant result, which suggests that personalized fluid resuscitation should be prioritized over the fixed volume approach. Regarding our secondary outcomes, such as duration of vasopressor therapy and requirement for renal replacement therapy, we found no statistically significant or clinically highly relevant results. But I have to highlight the fluid therapy can save more life than we expected. So our study has some strengths and the limitations as well. The strengths are that only RCTs were included, and this is the first meta-analysis indicating that personalized treatment has potential outcome benefits in septic patients, but the study is limited by the low and or the moderate and the high heterogeneity during, across the studies, and and it is meaningful that different techniques were used for assessment in the intervention groups. As a conclusion, personalized fluid therapy, fluid management may improve survival as compared to conventional treatment. Therefore, personalized approaches should be facilitated to become a standard of care, and the best way of personalized strategy has to be further studied in the clinical research field. The first version of the manuscript is written, and we are improving the discussion part, and it will be submitted in the next month. Let me talk about my second project, which is investigating the effectiveness and safety of immediate vasopressor initiation in patients admitted to the emergency department with shock. This is a protocol for the randomized controlled trial. Shock through hypoperfusion leads to organ failure and results in a high rate of mortality. Hypertension, it's an alarming signal of hypoperfusion, and as it was found that hypoperfusion increases the risk of MACE and acute kidney injury. However, if you can see the picture, you can see that the lower map and the longer time spent in shock significantly increases mortality. To avoid all of the above, fluids and vasopressors plays a pivotal role in restoring circulation. Current guidelines recommend fluids first and vasopressors as a second-line treatment, but there is no clear evidence on the time, which is a crucial part of critical care, when the vasopressor should be initiated. Our aim is to investigate the efficacy and safety of immediate vasopressor combined fluid therapy in patients admitted to the emergency department with shock. This project is supported by a recently published randomized controlled trial as well. Our clinical question is, does immediate fluid and vasopressor initiation enhance shock reversal without causing harm in ED patients with shock? Our population will be patients admitted to the emergency department with undifferentiated shock. In the intervention arm, patient receives fluids and vasopressor simultaneously after enrollment into the study. And the control group's patients will receive fluids first, as the guideline recommends, and if they are fluid unresponsive, they will receive vasopressors as well. Our main outcome will be the rate of persistent shock after 3 hours of resuscitation, and the secondary ones will be 30-day mortality, ICU admission, and length of stay and SOFA score changes. Our hypothesis is immediate initiation of vasopressor leads to better outcome in ED patients with shock, and if it's true, it will result in enhanced recovery from shock. To summarize, I have 2 ongoing projects. The first one will be submitted next month in September, and the second one will be submitted in next October. I would like to close my presentation with a quote from Theodore Roosevelt: "Believe you can, and you are halfway there." Thank you for your kind attention.
I'd like to ask then my question, what techniques were used to do the individual measurement?
For the individual measurement, there were no 2 identical studies. Most of them use ultrasound tool, measuring the IVC diameter, measuring the stroke volume, the increase in the cardiac output. One article used cardiometry, one article used echocardiography as itself, one article, which was the best one, I think, in my opinion, lung ultrasound and echocardiography combined. I think the most appropriate way to assess the patient's fluid responsiveness is to evaluate the patient's own heart function. And this is the basis, and it can be added any more tools, but this is essential and have to be included in the assessment, the stroke volume, the cardiac output, and the patient's own heart function. Because one of the study reported that in the intervention arm, regarding the fluid therapy, in the intervention arm, patients received a significantly higher amount of fluid in the intervention arm compared to the control arm, but it didn't produce harm, and this study was that used the stroke volume and the heart function to evaluate the patient's fluid responsiveness.
How much amount of fluid are we talking about? What's the difference?
Across the studies, the minimum and it was reported in different times, and it was a cumulative fluid balance, the study fluid and the study period fluid, but the minimum of the amount of fluid was 1,500 and at most 6,000 or 7,000 milliliters fluid.
Thank you.